Hi, my name is Dr. Arnab Datta, MD. I'm a psychiatrist, and I'm here with my co-host and colleague.
Hi, I'm Dana Davino. I'm the clinical director of Silverlake Support Services and soon to be PhD.
So I'm the medical director of this great clinic, RevCore and Silverlake in Staten Island and New York City. And I've got my own private practice, which is called Tresna Mental Health. And today we're going to be talking about Emily again. Emily is not a real person. She's a hypothetical case. And we would never present one of our actual patients or clients like this. And this is a continuation, a deeper dive from our first video. So today you're going to hear some clinical language. And a lot of times in society, people say, "Are you analyzing me? I'm not your patient," when they come across a psychiatrist or a psychotherapist socially. So what people are concerned about when they say this is folks don't want to be judged prematurely. People want to be heard, they want to be seen and understood. And psychiatrists, psychologists, we work really hard to listen with an open heart and an open mind in society as well as in clinic. So there's a difference between superficial clinical language, where the patient or client feels judged and not entirely seen. There's a difference when it's superficial judgmental language in society that's not really informed by psychology or emotionality. People, that's what people don't like. What you're going to see here are none of those things. Instead, we're going to give you a glimpse, sort of inside information, how we listen to a person, how we understand them deeply so they can overcome their struggles and become stronger emotionally. And even in society, people sometimes don't like hearing these stark truths, you know? So please leave this type of exploration to the professionals. Also, the way that someone might react based on certain experiences in their life, call it traumas, call it negative experiences. We know how to empathically handle this in a way that will help the person. So, Dana, how does that sound?
Sounds good.
All right. So, I'm going to give you a summary of the hypothetical case of Emily that we had presented in our first video. In our first video, Dana had recited that in totality. I'm just going to give you a quick synopsis of it. So we started talking about Emily. She's a 28-year-old woman, and she was brought into treatment after her third suicide attempt, after she and her fiance broke up. So Emily had a problem with alcohol, prescription painkillers, and she's coming up to us in a sort of a state of treatment resistant conditions. Allow me to explain. So Emily, she was in a situation where she had lost her job, she had strained relationships, she had some legal issues. After the breakup, the substance use started escalating. Okay. She had some problems with anger and frustration, even when her family or the fiance's family came to intervene and to see what kind of help she needed. So Emily's first suicide attempt happened when she was 16. She was hospitalized for 2 to 3 days, and that was after a heartbreak with a significant other. Her second suicide attempt happened when she was about 21 years old after she tore her ACL. And that's when she was prescribed oxycodone, pain management medications, and overdosed. Okay. So in our first video, we talked about how Emily was the youngest of three. Her father was a high functioning alcoholic, and her mother was often emotionally unavailable and struggled with depression. Now, Emily felt neglected by her father, and she didn't feel like her mother was really emotionally there for her. Emily started drinking in high school, and one of the things that really helped Emily was that she found soccer. She played soccer in high school. It really helped build her identity. She played soccer in college. She was an A and B student. She found a lot of camaraderie with her soccer team, with her teammates, with her coach. That's why when she tore her ACL, she got addicted to the oxycodone pain pills, overdosed, dropped out of college. Emily went to therapy. she started dating again, and eventually she got engaged. Emily selected a boyfriend, eventually a fiance, that was kind of like her father in some ways. He was a good provider, but he would also drink alcohol. Emily was still suffering from insecurity, jealousy that caused problems in her relationship. And one day when the fiance was sleeping, Emily saw a text in his phone from one of his previous partners. The text was purely informational and just said that a mutual friend had died. But this sort of reminded Emily of bad experiences in the past. Emily was felt triggered by this because her perhaps her experience with her mother and father when she was feeling neglected and not understood. So Emily and the fiance would fight, but it wasn't the first time. They would fight like this often. But this time, the fiance was so frustrated that he broke up with Emily. And so that eventually led to Emily's third suicide attempt. It also led to a psychiatric hospitalization, her third one. And then she came into our clinic. So one of the things we're going to talk about, we have been talking about, is the constellation of a trauma history, developing certain personality traits, such as borderline, narcissistic, how this can lead to possible addiction. We mentioned neurodivergence in our first video, and sometimes borderline folks, they will sometimes go back into the relationship, even though there were some things that were not so good about the relationship. So Dana, how does that sound so far?
Yeah, that sounds like a great summary of Emily and what's going on with her. Okay, so when we're looking at Emily, we want to know a few things, right? We want to know, where does this reaction come from? Why is she thinking that her fiance is doing something wrong or cheating or pushing her away, right? So when we're looking at this, we're looking at unresolved trauma, and it often manifests in borderline traits, right? We see that she's using substances. So for Emily, the substances are a form of coping, right? Those are her coping mechanisms, and it's also a form of self-punishment. So we see her behavioral addictions. We can also see sex addictions that can play a similar role. Emily has some unresolved unconscious conflicts that are playing out. And one of them that we see with her is repetition compulsion. So repetition compulsion is this framework of what relationships look like and feel like. And we see that as Emily was growing up, both of her parents were unavailable. And she has this certain experience. So in Emily's mind, she has associated chasing with love. So when we see that she's going into another relationship, like with her fiance, there's this need to constantly chase to receive love, right? It's not that it's a comfortable situation for her, but it's one that she's drawn to because she's familiar with it, right? We also know that growing up, Emily felt abandoned, right? There was an emotional abandonment. She had experienced childhood trauma, exposure to an alcoholic parent, emotionally neglectful mother, and that disrupted her secure attachment, right? Or the development of a secure attachment. And this trauma can manifest in hypervigilance, mistrust, fear of abandonment, and definitely emotional dysregulation is what we're seeing in Emily. Right? So people with borderline personality often have these characteristics, right? They have a pattern of unstable interpersonal relationships, alternating between extremes like idealization and devaluation. Somebody's the best and then they're the worst. And her accusations during those moments of intense jealousy are characteristic of that dysregulation.
Yeah, so this is right on. Sometimes these trauma survivors with borderline traits, they have inappropriate intense anger. They lose their temper. They have recurrent physical fights. Sometimes they can interpret a good person or even a provider who tries to help them as not so good. They may have a poor experience with doctors, even when the doctor is not being cookie cutter rather trying to give customized care. This is similar to the idealization, devaluation that had happened at home, and it also repeats in the therapeutic space. We see some of these inappropriate bouts of anger in Emily's childhood when she really wanted her father to be there, but the father was not present, maybe too indulgent in alcohol. And when the mother was there, she was not that emotionally supportive. So Emily didn't really know, am I going to be loved? Am I safe at home? Is somebody going to understand me? And so that's why when Emily started playing soccer, it was so good for her. She became an A and B student. She excelled at the sport. She did well in school and social life, but then everything kind of declined when she injured herself and she got that ACL injury. So in therapy, Emily might transfer her feelings of anger and betrayal from her childhood onto the therapist. They might find friends and family members of being unempathic, trying to control her. So the therapist must navigate these dynamics very carefully. And we must avoid reinforcing Emily's sense of abandonment and her sense of control or loss of control. And Emily's resistance to this, it might lead out to feelings of burnout or feelings of inadequacy in her friends, in her family members, like it did with the fiance. So this is called projective identification. Okay. Emily's anger and feelings of betrayal and hurt that was already there from childhood, adolescence, and growing up, it gets put onto the friends, the family members, the provider. And we're going to talk about this more in our next video. And so these trauma survivors with borderline traits, they have also some identity disturbance. They may have an unstable sense of self, which also emanates from the inconsistent or neglectful caregiving during childhood. And in treatment, we're going to try and strengthen these things. Okay. Sometimes these folks, these patients, these clients, they harm themselves. They're sometimes cutting, they're sometimes overdosing, and that's a way to cope with these overwhelming emotions, particularly those linked to rejection or perceived rejection or abandonment, or if someone didn't really listen to me. Okay. So sometimes Emily might tell herself, if I don't do this myself, I'm going to hurt myself, I'm going to sabotage this situation before you can do that to me. If I push you away, I don't have to feel the shame or the hurt of you rejecting me. So I'm going to sabotage it first. If I hurt my body, well, you can't violate me. Again, now I'm in control. Okay. So these are like defensive maneuvers that are disguised as recklessness. And it's also very negative future fortune telling, which is a cognitive distortion. So when Emily relapses on alcohol or oxys, it's not just a failure. Emily is returning to what she's familiar with. It's harmful, but it's familiar. It's like a self-fulfilling prophecy. And Emily can say to herself, and in treatment, we eventually want to grow towards Emily obviously not thinking of herself in this way. See, I'm still the same broken person. I deserve this. So staying healthy or off drugs might sometimes feel alien to her. So she has this vicious cycle of reaffirming the core trauma, the core shame. And in treatment, we are going to try to heal this vicious cycle. So emotional dysregulation stems from the inability to process attachment-based emotional triggers. A lot of these clients, their mood goes up and down. We call that affective instability. This treatment, DBT, dialectical behavioral therapy, helps a lot with that. These folks, they'll have chronic feelings of emptiness, from the attachment wounds from back in the day. Sometimes they'll have the recurrent suicidal behavior. They'll have substance abuse. There will be some reckless sexual behaviors, sometimes reckless driving, binge eating, or spending. And so how does that sound so far, Dana?
Well, that sounds exactly like what's going on with Emily, right? So, it's interesting because for Emily, she's not the one who's volunteering to come to treatment, right? So Emily is being coaxed into treatment by the people around her, which is something that we often see with personality disorders. Um, she's more likely to respond to treatment because of the influence, but not to come to treatment on her own accord or take the initiative. Right. So we see Emily, she's using oxys, she's drinking. It's not just impulsive or bad decisions. There really are desperate attempts to self-regulate. So the brilliant brain is in pain and says, let me figure something out. If I take this, I can numb that feeling. So her drugs of choice, the drugs that she's choosing, are central nervous system depressants, right? We have alcohol, we have oxy, and they're giving her this feeling of calm and numb, being numb. And, addiction can manifest in a lot of ways, like you said earlier. Sometimes it's compulsive spending, it's fantasy fulfillment, sexually acting out, all of these different, all these different types of addictions. But really, for her, she's seeking a way to dissociate or separate herself from the pain. So that's basically what we see with Emily, typical with borderline. Um, for her, there's this fear of not being wanted, right? So borderline develops from this fear of abandonment. So the idea of being wanted really gives her this sense of safety. Um, yeah, especially when it's like the physical act of sex. When she's engaging in sex in that moment, it keeps the fears at bay. But once that is over, then it comes back and she wants to re-engage in that behavior again because it did get rid of the fears. Basically, what Emily is doing is trying to separate herself from the pain.
Right on, Dana. So one of the treatments, one of the therapies that's super helpful is DBT, dialectical behavioral therapy. There are other treatments too. See, there's some drug use. Motivational interviewing is the therapy for substance treatment. And sometimes psychodynamic psychotherapy, where there is some exploration of the unconscious mind, is helpful. Sometimes CBT is helpful, which is a more goal-oriented therapy, but also has some unconscious digging. So in DBT, that's going to be especially helpful. And DBT, it starts with listening to Emily and validating her experience, but in a skilled way. The therapy, it should give Emily, you know, some tools how she could safely regulate her emotions, how she could eventually stop the harmful behaviors, the reactivity, okay, the irritability, the self-harm, okay? So DBT, the four pillars of DBT are distress tolerance. When things aren't going your way, how do you reduce this distress and how to regulate your emotions? So emotional regulation is the second pillar. Having those down, you will be more interpersonally effective. So that's the third pillar of DBT, interpersonal effectiveness. And mindfulness sort of, it helps everything sort of come together. So this art of psychotherapy and meditation and mindfulness, very helpful in this art of DBT. So this type of therapy, it really listens to her. It helps her understand how to cope with how she's feeling in order to be more healthy in how she is with herself and with others. So in treatment, the trauma-informed therapist, we don't frame these patterns as Emily's non-compliance or poor judgment, okay? Instead, a better way to talk to the client is, Emily, this is the best way you knew how to protect yourself. You weren't broken, you were adapting. But now we're gonna learn a new way. So the therapist must track, the attachment history, some of the somatic, survival responses that Emily learned that might have not been so helpful. And we got to teach her more helpful ways of doing that. And we got to understand the unbearable vulnerability underneath Emily's acting out. So we're not just treating the behavior, but the meaning beneath the behavior. So Dana, how does that sound?
Yeah, it sounds like we're treating the person.
So thanks for joining us on this video, and stay tuned for our next one.
Bye, everyone.